Disclosures. Dr. Wallenkamp has several disclosures not related to this talk. Okay, so everyone, welcome. This is CPC, Clinical Pathologic Conference. The case for today is the case of a 59-year-old female, past history of hypertension, diabetes, presents with fatigue, nausea, decreased appetite, and weight loss. Our expert clinician here is Dr. Kieran Patel. A little bit briefly about CPC history. This is really to help inform our applicants who may or may not remember from their interview day. So CPC was actually originally based off of case law. For those of you who are familiar with the law school law training, they would evaluate cases and discuss them. And back in the day, there were physicians at Harvard who knew people at the law school, and they're like, hey, we should do this in medicine as a way to kind of enrich and discuss cases in medicine. Dr. George Dock was our first chair of medicine. He saw this at Hopkins, went from Harvard to Hopkins, saw it at Hopkins, and then brought it here. And we've been doing it ever since. So it's been a very cherished tradition we have here. One of the things we like the most here at WashU in terms of our education. But let's talk about Dr. Kieran Patel. So about Dr. Patel, he's an instructor of medicine here in our division of hospital medicine. He did his undergraduate work at University of Delaware and the medical school at Drexel, and then residency here, where he actually served as chief resident a couple years back. And then since then, he joined as the hospitals division and has been an excellent mentor for the residents, helping out in multiple different facets, from teaching service to the clinical competency committee and many other forms as well. So we are very lucky to have him here. He has a couple here, 59-year-old female with past history of hypertension, diabetes, presents with fatigue, nausea, decreased appetite, and weight loss. Dr. Patel, what are your thoughts when you first see this one-liner?
Yeah, so maybe I can start with just generally how I approach problem solving, because this was incredibly non-specific and very unhelpful to start with.
I apologize.
So usually when I'm approaching a problem, I'm really trying to define actually what that problem that my mind is trying to solve. What am I really working on here? And that really comes down to trying to separate the signal and the noise. And then I kind of break it into two main factors, like what do I know about this patient, and kind of what are the risk factors of that patient? And I think a couple things that really play into that I consider highly are the age, some of the past medical history, meds, social history, and I'll kind of break that down how it applies to this one-liner in a second. And then the second thing I really look at is the clinical syndrome itself, and I'm trying to understand really time course and localization. Those two things are usually the most critical for me, but I think severity is one that maybe gets a lot of attention, because if it's obviously very severe, we have to usually treat before we're diagnosing. So those are kind of how I approach problems. So when we apply it to this case, you'll see that there's not a lot of help, but age. So she's older, so you automatically start to think, could her chronic comorbidities could they start to have some degree of complications? And this is a manifestation of that. Malignancy immediately jumps to mind. And then in terms of her past medical history, this diabetes and high blood pressure, I'm really going to be curious about how well controlled those are as I kind of walk through this case. And it makes me begin to at least entertain the possibility that there's a vascular risk factor here, and maybe that could be contributing. Gastroparesis was also one thing that came to mind. Meds, I think she's diabetic, GLP-1s, they're in vogue. We've definitely seen people admitted to the hospital with dehydration and failure to tolerate after starting these medications, so I'm curious about that. Hydralazine, given her high blood pressure, is one that could potentially present with a syndrome like this, but mostly in the vein of like a drug-induced vasculitis. I would not even be entertaining or considering that if this wasn't CPC, but I'm just throwing it out there. In terms of her social history, weight loss, decreased PO intake, I'm really interested, is she a smoker? Does she abuse or use any substances, alcohol? Those things will help kind of reorder the probability of different processes in my mind. Yeah. So then we can kind of move forward and look at the clinical syndrome itself. And I saw fatigue and nausea, and I was like, these are just incredibly not helpful symptoms, right? They're often bystanders. They're not really the focus of the case. So not even really going to think about it right now. The caveat to that, though, is severity, right? If she tells you she's throwing up every 30 minutes, 40 minutes, the severity does sometimes give you some localizing value to a symptom. So I'll be listening for that, but I'm going to forget about nausea for the time being. And I think a good example of severity being like a localizing helping to localize something is the worst headache of your life, right? most times people have headache. The problem's not necessarily in the brain, right? You have a URI, you have a migraine, you might be nauseous. But here, if you have the worst headache of your life, you immediately think, like, could this be a subarachnoid hemorrhage? And so that's a kind of just an example I thought of there. So moving further down the list here, I get to weight loss. And usually in my mind, weight loss immediately makes me think of inflammation. But I think that connection becomes a little less powerful when we have the preceding like decreased appetite. So now I'm really wondering, why isn't she eating? And that's probably where I'm going to go first. So if you go to the next slide. Now, this is busy, and I think it just goes to show you that how nonspecific the symptoms are to start. And basically, we don't have a problem that I think is worth solving just yet. Because look at all this. This could be anything, right? You know, too little in, too much out. But the problem is usually it's a little bit of both, right? You can imagine someone with chronic inflammation not feeling well, then not eating as much. But I guess just because this is CPC, I'll focus a little bit on like the decreased appetite portion of this. So like, why isn't she eating? And there's three things I start to consider. Is decreased appetite, like depression, dementia, maybe there's some medication kind of contribution to that, like we discussed before. And then is there some chronic illness, like end stage heart failure with cardiac cachexia? Is there end stage renal disease and they're just not eating? We see that quite a bit. Then I'll think about, is there any reason why this patient can't engage with the actual swallowing mechanism? Is there any oral or dental pathology, problem with the salivary glands, problems with the esophagus? And so I'd be asking questions like that, and what I'm going to be listening for specifically when you give me a little more history. And then finally, I just entertain like distal pathology. And I think the one that probably makes this point the best is like, if someone has really tense ascites and they feel very full, they're not probably going to be eating as much, and they tend to lose weight rather rapidly. So that's what I'm thinking about so far. And then if you go to my last slide, I think the things I'm thinking from a reasoning standpoint here is trying to really avoid premature closure. So we could focus on the weight loss, but I don't think that's really the problem that we're ultimately going to solve unless you tell me it's absolutely severe weight loss. So otherwise, I'm just going to kind of stand back, let all the information hit me, and hopefully something jogs something in my mind and I have something to talk about. So I'll be looking for that hook.
Yeah, that was super informative. I want to go back to this slide and kind of highlight, as clear as that, I think all of us in some form or fashion have seen a patient with very vague symptoms, and how are you able to really parse through those symptoms and get the information that you need? And all these things are very helpful, like Dr. Patel pointed out, to actually better stratify, form a differential, see where these issues lie, and then form a differential, and then start the appropriate questioning and work off of that. So thank you for going through that, getting all the information with the little that I gave you, or I guess not specific stuff I gave you. Let's hop into the HPI though. So this patient started experiencing kind of all four of these symptoms: nausea, vomiting, decreased appetite, fatigue, starting about 1 month ago. The thing that she actually is most bothered by is the fatigue. That has progressively worsened. She used to be able to do all of her daily activities, do whatever she wanted, no issues whatsoever. But now she feels like she needs to stay in bed all day because she just does not have any energy whatsoever. She noticed that she did have several episodes where she felt like she was going to faint, and then did have 1 or 2 episodes of syncope that occurred when she stood up. And then she also noted that she's been unable to keep any food down due to nausea and vomiting. She says it's like something she eats a little bit of food, then immediately just wants to throw back up. And because of that, she's lost 25 to 40 pounds in the last month. So now that we have a little bit more information, how does this now shape based from what you said before?
Yeah, I mean, I think you gave me weight loss and immediately we're in the subacute to chronic category. There's not a lot of things that cause acute weight loss, right? Unless you're diuresing someone or they're hemorrhaging out. So I'm glad to kind of clarify the time course here. The fatigue is interesting, but again, it's still rather nonspecific. I think what I'd be trying to really parse out here, is this actually fatigue or is there some semblance of weakness here? And so I would just be kind of asking clarifying questions when I'm examining this patient, trying to understand that. But it does sound like this could all be related to her weight loss. And so again, I think we're stuck left asking the question, why isn't she eating? And so I'd be really like diving into those questions about her appetite and exactly what's happening when she's eating. Is it getting down, getting stuck, and then coming up? Is it getting down and then maybe an hour later it's coming up? So all these questions are starting to kind of percolate in my mind, but it's very clear that this is quite substantial weight loss. And it does make me start to think that we're localizing to the GI tract right now rather than anywhere else.
Yeah, great. Are there some, I actually don't have any more of the HPI. There are some questions you want for clarification in that you mentioned that I can
Yeah.
provide.
So I guess just like really going through what happens when she eats food is what I would be trying to ascertain.
Yeah. In this case, she's able to swallow the food, feels like it goes down all the way. The exact time course of like, is it 5 minutes, half an hour, or something like that is unclear, but pretty soon after eating the food, I would say probably within the hour, she gets really nauseous and wants to throw it back up.
Mm-hmm. And the vomit looks
Yeah,
normal.
yeah, it's just the food that she ate, no blood or any other concerning colors or changes in it.
Got it. And her appetite's normal. She actually has the desire to eat.
To some degree, I think with everything going on, she did notice decreased, like she's not as hungry as much, but I think it's made, I don't know if that's because she's afraid of, she doesn't want to be nauseous and want to throw up. So her body's reacting to that versus a more intrinsic, like, oh, I just don't feel hungry feeling.
Right. I think the other things you immediately think is you're going to do a full GI review of systems here. You're going to ask about the quality of the bowel movements. You're going to want to make sure this person isn't actually just having severe constipation. The probability this is a bowel obstruction going on for a month is unlikely. But there's, I'm looking and screening for red flags. So blood, severe pain. I haven't even heard pain yet, which is actually kind of interesting to me, the lack of pain. I don't know if you're just not telling me that or if, but I guess all I can really say at this point is we have a female. It sounds like her past medical history is not super interesting just yet, but maybe about a subacute, pretty severe weight loss. And I'm worried about her GI tract at the moment.
Yeah, no pain that she reports. But I think we'll see in just a second. But no severe pain is really her problem here. So a bit more about her history. Her medical history is relatively benign. Hypertension, history of diabetes. But I will know her A1C on this admission was 5 actually. But previous history still on treatment, as you can see, and hyperlipidemia. Surgical history is significant for C-section for her children, ACL repair. No contributed family history, no allergies. The medications are listed there: glipizide, losartan, lovastatin, metformin, pregabalin. And then social history, she has a 20-pack year smoking history. She occasionally drinks some alcohol just socially, maybe a couple of drinks a week, if that. No other drug use, and otherwise she just lives at home with her spouse in the city. Nothing too concerning for any travel or any other exposures, anything like that.
Perfect. So, it's hard for me to really link hypertension to this presentation, so I'm kind of going to table that for now. The diabetes seems pretty reasonably well controlled. She's not on insulin. I'd be very surprised if this was something like diabetic gastroparesis, especially because it's CPC, but just kind of going through my thought process. Again, she has all these vascular risk factors. You add in hyperlipidemia, you add in smoking. Could this be a presentation of mesenteric ischemia? This is kind of like the right time course, but there's no pain again. So a little bizarre and weird to me, but I'm not going to completely rule that out right now. Her prior C-section does put her at some risk for adhesions, and so some sort of obstructive process is still kind of percolating in the background, but this doesn't seem totally consistent with that. I would expect a much more rapid and onset and kind of to the point where she would have presented earlier. The meds, I really, none of these stick out to me as being problematic directly at the moment, and I don't see a GLP-1. And then really from the social history, the smoking history just really makes me somewhat concerned about a cancer history. So I'd be curious if she ever had her irregular colonoscopy.
So this is the first time she presented to Barnes, and the other records are pretty sparse. I don't think she is up to date with those cancer screenings. That's the best I can tell.
Yeah, so I think we're still stuck. I keep saying that. I don't know if anyone has better ideas, but this still is very non-specific, and I'm still really looking for something to add on to this weight loss to help me really start to kind of make any further progress. All I can say right now is I would probably be really interrogating the labs, and I'd have a pretty short trigger to pull on imaging in her because I am worried about the GI tract. But that being said, with the lack of clear and overt inflammation in the GI tract, there's a chance that even if we did image her, it could be completely negative. And then at that point, you're really kind of looking at some sort of scope.
Yeah. We'll go to the review systems in a second. Actually, I'll show you the review systems, and then I have a follow-up question after that. So here's the review systems. Positive for the big things. The things that I would add on, the things we talked about. Things with add on is that she did endorse some diarrhea. There's no blood, no tarry colored stool, anything like that. but just looser stools and increased frequency, maybe 3 or 4 times a day more so than usual, or once a day. Otherwise, it seems kind of in line with not a lot to hang your hat on at this point. So the next thought, I guess, additional thoughts here. Given that we're not really seeing much on the history and the HPI, what on exam will you be looking for that can to maybe help you give you a better sense of direction?
Yeah, yeah. I mean, I think this case is nice just because we're really having to sit with a lot of uncertainty, and that's uncomfortable, right? Like, especially as trainees, your attending is going to be looking at you and saying, "What the heck's wrong with this patient? Give me an answer." And so sometimes it's okay to not have the answer, and that's just, you know, quite all right. And I just want to normalize that feeling for myself mostly in this moment, but also for you guys. So on exam here, I think I'm really going to look in this lady's mouth. I want to see what's going on in there. And then I think the skin exam's helpful too. You know, she's lost enough weight, but the time course is kind of short. But, you know, you might start to think of some nutritional things. And then I'm looking for any evidence of other kind of chronic diseases. Is there jaundice, cirrhosis? Yeah, I mean, the symptoms are so vague. Obviously, I'm going to do an abdominal exam, but I think unless you tell me there's something positive on an exam, I don't think I'm going to make any much more progress.
Okay. I will stop torturing you. I think we'll have a little more information on the exam. So her vitals are relatively stable, all things considered. She's a little bit overweight. The things that stand out, she's well appearing, no acute distress at this time. On HENT, she has dry mucous membranes. You can see in their mouth. Scleral icterus is present, as well as conjunctival pallor. Cardiac, pulmonary, abdominal exam are pretty much within normal limits. You can tell that her skin is jaundiced, but no other rashes, no spider angiomata, pulmonary erythema, nothing like that. Otherwise, the rest of the exam is pretty unremarkable. So do you think we're getting some more information that can help steer us a bit more based off this?
Yeah, I mean, jaundice stands out immediately, right? And I think the biggest question when I see someone with jaundice is this a blood problem or is this a liver problem? And so I'm going to be interrogating the rest of this lady's labs, her vitals, her exam to really help me kind of make progress. Is this hemolysis or is this really cirrhosis? So her blood pressure might be the first clue. We know patients with cirrhosis tend to have lower blood pressures. I would kind of pause and wait before I make that jump until resuscitating this lady. She is pretty dehydrated, presumably, based on the story you're giving me. But that might be our first clue that this might be more of a liver GI problem than a blood problem. Otherwise, the dry mucous membranes, not too surprising there. There was no lesions in the mouth. The tongue looked normal. Okay. Scleral icterus, no surprise. Typically, to start to show signs of jaundice, you have to have a bilirubin of about 3. And so I guess really we're stuck still trying to figure out, is this indirect hyperbilirubinemia or direct hyperbilirubinemia? The conjunctival pallor might be a clue here that this is a sign of anemia and that this could be the first hint of a hemolysis process. But it's really hard to say at this point, just given that people with cirrhosis are often also anemic. So I don't know why she would have cirrhosis. So I guess maybe I'm putting anemia a little bit higher and potentially hemolysis for now, given that I'm not hearing or seeing any other signs of chronic liver disease like pulmonary erythema or spiders.
Yeah. You mentioned a couple times kind of paying attention to her tongue and the skin exam. Kind of what were your thoughts initially when you brought those up?
Yeah, I kind of hearkening back onto why this lady's not eating. I think the mouth is an unforgotten wasteland. We never really want to look in there because it's often, you find things you don't want to see.
Those dental caries.
Or you don't see things that you want to see. So, I'm wondering, does she have good dentition? And then, the tongue might be a place where you start to see some nutritional stuff show up. That's all I really remember about that. Dr. Reeds might be able to kind of add more, but I just remember glossitis and like nutritional deficiencies. So I don't know necessarily what I do with that information as much, but I do look.
Okay. Always good to make sure we're very thorough in our exams. All right, let's start looking at some labs. So on her CMP, significant for her sodium 133, chloride's a little bit down as well. The remainder of her BMP side of it is normal. On the liver function test, her T-billy is elevated at 5.4 with a D-billy of 0.2. AST is up to 102, ALT is with a normal limit to 18, as is the rest of these labs. Thoughts?
Yeah, so the hyponatremia, it's mild. She's pretty dehydrated. I would want to really know what that looks like after fluids before jumping to say, she's got cirrhosis, and a little hyponatremia associated with that. So tabling that for now. The rest of her BMP is pretty unremarkable to me. Now, looking at her liver labs, we have an indirect hyperbilirubinemia now. So this wouldn't really fit with cirrhosis. We're kind of firmly in probably saying this is some sort of hemolytic picture, given the fact that the AST is also elevated. What's impressive is she's hemolyzing a pretty good amount. Typically, you don't see T-billies higher than 5 in hemolysis. So she's got pretty impressive hemolysis. I'm going to be really curious to see what her hemoglobin is. I suspect now that that's probably driving a fair amount of her symptoms.
Yeah. Ask and you shall receive. On her white count is 0.7, with a hemoglobin of 4.6, platelets 35, the MCV is 112, and your absolute neutrophil count is 400 or 0.4.
Yeah, so looking at this, I would call this pancytopenia. Very impressively low WBC count. I'd be looking at the differential of that to help me a little bit more. I'd be circling back as well as I'm examining her, kind of really asking infectious review of systems, because now we have a real concern that she could have not only normal infections, but also she's immunocompromised potentially and could have infections related to that. The hemoglobin is impressively low at 4.6. I think the fact that she made it this long does suggest some degree of chronicity to this. But we can we say that's all hemolysis? It's impressive to say that this would be all hemolysis and no evidence of bleeding. And, she definitely has a bleeding risk factor here with the platelets being so low. So when I think about pancytopenia, it's a ginormous differential. But typically, I think about like systemic things that could do it, like lupus. At her age, I wouldn't really worry so much about that. Splenomegaly. I think about substances as well. So things that are directly toxic to the marrow. I think things we see a lot of is alcohol and chemotherapy doing it. But then you also need like nutrients for the body to make blood as well. And so I'm thinking about whether or not she could have a nutritional deficiency given how much weight loss she had. It's hard for me to tease out if what is driving this is what has caused her to become nutrient deficient, or did she have a nutrient deficiency that then led to this point? That part I'm not sure about yet. The interesting thing is her MCV here. It's really pretty high. And that's actually got a good degree. That's actually a pretty good diagnostic clue here. So you might say, hemolysis, she's going to have reticulocytosis. Yes, like she should have an elevated MCV, but when the MCV gets above like 112, there's really like two things that do that. It's rouleau formation, and you're like tricking the CBC machine into thinking that, or it's B12 deficiency. So that I think is my real big clue here, that this potentially could be some degree of B12 deficiency. And then the question really becomes, well, why would she be B12 deficient? Can you go back to, she was on metformin, right?
That's correct.
So I know metformin is highly associated with B12 deficiency. So, I'd be worried about that. I'd be sending a B12 immediately, a folate immediately. And then I would be obviously doing an infectious workup, HIV. I'd be sending all my pancytopenia labs kind of at this point, but I think that would be something I'd be worried about up front. When you do see anemia and thrombocytopenia, I always pause and I always tell the residents, well, what can't you miss? And the one thing I wouldn't want to miss is like a MAHA here. But, it's probably not TTP. It doesn't appear to be DIC. Could it be like, HUS or atypical HUS? With normal renal function, it's kind of hard to entertain all those things. And usually they don't have such a profound deficiency in the white count. So the overlap I'm trying to make here, I guess, long-windedly, is what can cause someone to have pancytopenia and hemolytic anemia? And I think B12 kind of does that nicely.
Yeah. I would say there is that little pop-up that usually happens that says normal diff, which actually, this is a normal diff this time. I just decided to delete it from before, but it is a normal differential. It just, because her white count is so low, her absolute neutrophil count is low as well. Before we go into diagnostics, you mentioned some of the kind of infectious stuff. Would you, we worry about neutropenia. I think we often see neutropenia more so in patients with cancer, especially BMT patients. In this case, would you prophylactic, like start her antibiotics or would you maybe like, hey, let's get some blood cultures and do the chest x-ray, all that stuff first and hold off antibiotics?
Yeah, I mean, you definitely need to do an infectious workup here, I think. I think blood cultures are definitely reasonable. I'm trying to think of the infections that really cause pancytopenia, right? And I start to think about things that actually infiltrate and get into the marrow. So like your endemic mycoses, some weird tick-borne infections, things like that. But we don't really have any other reason to suspect that other than pancytopenia alone, right? I didn't hear anything crazy. But I think it's reasonable at least to do a full infectious workup on her at this point. No one would fault you for starting antibiotics in them, but I don't know what I would be treating at the moment.
That's fair. To give you a little bit of a just brief clinical update, she did get units of blood. Her blood pressure did get a little bit soft while in the emergency room. But once she was volume resuscitated with and also packed red blood cell resuscitated, if you will, her blood pressure did improve and she went to the floor.
I'd be a little remiss without talking about cancer here as well, like especially blood cancers, leukemia. Could definitely present somewhat similarly. I guess I'm trying to stop the pattern recognition I'm having with the MCV being so high. So if I ignored that, then I would definitely be a lot more concerned about infection, specifically malignancies infiltrating the marrow or blood cancer specifically.
Like you said before, you want to avoid premature closure. So, all right. So what additional diagnostics do you want first? And here's our fun choose your own adventure part. So which would you like to start off with? You kind of hinted at what you like.
I would love to see her B12.
Okay. So it's a B12 and folate. Would you send any other kind of anemia labs? You know, usually think of like the iron labs, the hemolysis labs. Would you just send all of it and see what happens, or be more selective?
I think you would check her hemolysis labs. LDH, haptoglobin have really good sensitivity and specificity for detecting hemolysis. So that would be somewhat helpful to send. I had something else in my mind that I just forgot about. What else? Oh, the retic count would actually be pretty helpful here. If she's hemolyzing because of destruction, we would expect the reticulocyte count to be high. Now, there's always situations where you might not get the reticulocyte response that you would expect, like a concomitant iron deficiency or anemia of chronic disease. If we kind of suspend that reality for a minute, if she is hypoproliferative, that does make me a little more worried about maybe potentially a nutritional deficiency. So I would send that. I didn't see anything else on her BMP that made me terribly worried about like TLS labs, but I would probably send those as well at this point. I think a peripheral smear is probably advisable given that, you know, we are having hemolysis on our differential, though I'm not so worried about a MAHA right now.
Okay. Well, through the anemia labs. So as you can see there, ferritin's elevated. Her TSAT is extremely high. I don't know why the TIBC is not, it's less than 257. That's not a red number according to our labs. The B12 is a little bit on the low side. Haptoglobin is very low. The LDH is very high. I do have the reference CBC up here. They did consult hematology, and this was their read of the peripheral smear, which just decreased counts of all cell lines, no fragmented cells or schistocytes, normally segmented PMNs, and normal platelet morphology.
Yeah, I mean, very impressive. So I'm trying to think in my mind how this can't be B12 deficiency right now, just because I don't want to be up here being like, it's B12 deficiency. And then you're like, just kidding, it's ALL. So this is pretty convincing. No, the B12 lab, maybe we can talk about that for a minute. It's actually pretty crappy. And this is pretty much why anytime it's less than 400, that's still a normal number, but that might be, and if you're worried about symptomatic B12 deficiency, you might actually send the MMA level to kind of confirm. The MMA is definitely much more sensitive for B12 deficiency, but this is like objective. If it's less than 200, you've pretty much confirmed that she's B12 deficient. It's reassuring to see that the folate is normal, because that's like usually the thing you're grappling with clinically is this more B12 or more folate, or is it a little bit of both? I think here it's probably the B12. B12 deficiency usually takes some time to occur, typically on the order of many years. If I remember from med school, at least 5 years. So I guess maybe she just reached the critical point with her pancytopenia at this point, and that's what's driven her in. I'd be circling back and trying to understand her dietary history now, just ruling out that she's like vegan or very, has like no weird, like very restrictive diet. But most cases of B12 deficiency, you would, at her age, you'd worry a little bit about pernicious anemia if you were sure her GI tract was normal and there wasn't an offending med on board. So we have to make sure her GI tract is normal still, and then we still know that her metformin is there. So I mean, it's hard not to blame the metformin at the moment. Can you go back real quick? Did I miss anything?
Sorry.
Oh yeah, and then she's hemolyzing. We've confirmed that. Cool.
Great. So now where from here? You did mention the infectious evaluation, just given her neutropenia. So we'll go ahead and show that. They got blood cultures, nothing grew. COVID was negative. This is a couple years back, so they were just focused on COVID as opposed to the full RBP. And then they get a acute hepatitis panel too that was also negative. Basically, her infectious workup was pretty unremarkable. They did start her on ceftriaxone, but quickly in the emergency room, but then quickly stopped it once all these results came back. Where would you like to go from here? A few other options here. You kind of mentioned maybe GI pathology.
Yeah, I'd be curious to just double back and make sure she's never had a secret gastric bypass surgery and that she's not having any like symptoms consistent with like celiac disease. She's not like a closeted alcoholic who's got chronic pancreatitis. And so I think that's now the question is, all right, we have B12 deficiency. It seems to be causing pancytopenia. And then you're asking yourself, well, why are you so B12 deficient? And I'd be blaming the metformin unless I heard anything else.
Okay. So they did get some cross-sectional imaging of her abdomen, given kind of this concern for GI symptoms. It did actually show cirrhosis with signs of portal hypertension as evidenced by splenomegaly, but otherwise no acute CT findings in the abdomen. And I thought this is an interesting line. I apologize for the typo, but there is decreased attenuation of the blood pool, keeping with anemia. Not something I see very often. I think this was done when she was very anemic down to the 4 and 5 levels.
The cirrhosis is interesting. I wasn't necessarily expecting that. Why does she have cirrhosis? I don't know. Outside of like maybe she has a little bit of fatty liver or something that was lingering there. We'd have to double back and make sure we check her hepatitis labs as well in this setting. But that is a little bizarre that, okay. So I don't know why she has cirrhosis. I think if you look at all comers, her age with her predisposition of diabetes, you would worry about MASLD, fatty liver disease, what it was used to be called. So I'd be most worried about that. I'd be doubling back and asking about alcohol too. But, cirrhosis can cause hemolysis. You're making me squirm now. So it can lead to issues with the lipids. So I guess maybe I can step back and talk about hemolysis, how I think about it. I always think about it from the red blood cells perspective a little bit. And then there can be things in the environment. You're traveling through the bloodstream. You get shear up against like a fibrinogen plaque or something, and boom, you're dead. You're a schistocyte. You can run across a bad valve, right? Like a prosthetic valve. That can cause you to break down. Then the blood cell can be attacked, right, by antibodies. So that's, our autoimmune hemolytic anemias. The membrane itself can become altered with the lipids. We see that in cirrhosis. And then also there's like a weird thing when people drink alcohol, they can get Zeev syndrome. It's pretty rare, but that itself, and I don't think they know, well, at least I don't know why that happens, but they can hemolyze. There's anchors, GPI anchors in the red blood cell, and that's like, that can be messed up, and that's paroxysmal nocturnal hemoglobinuria. And then you can have stuff within the red blood cell that can cause hemolysis. So you can have G6PD deficiency, hemoglobinopathies like sickle cell, thalassemia. You can have electrolyte derangements, super high copper. That's why people with Wilson's hemolyze. But I guess I say all that to say, like, try to convince myself, you notice I didn't say B12 in that whole thing, but you can actually get hemolysis in B12. And I remember Dr. Wren standing up here. She had a very similar case, and it's intramedullary hemolysis. You're making such bad red blood cells in the marrow, they're breaking down, busting up, and you get hemolysis like that. So I don't think the cirrhosis really, I don't think I've seen someone with cirrhosis just hemolyze this bad.
Yeah.
So I'm still worried about and then we know she's B12 deficient.
Yeah. And just to answer some other questions, she's very adamant she does not drink that much alcohol. In terms of her diet, she says she eats normal diet, eats all different types of food, no concern for that. Is otherwise doing everything healthy without any kind of weird changes before all these happen. So just kind of where do you want to go from here? I got the options listed here, especially with kind of comments with the B12 deficiencies. Any other workup you'd want to do for that?
I didn't see an HIV. I think we should do that in RPR. I would like round out the infectious things. The other infectious things that come to mind with hemolysis specifically would be like malaria and babesia. I think Bartonella can do it too, but again, I don't really have any reason to suspect that. I don't think urine studies are going to help me too much. And I don't imagine cardiology is going to help me too much. Immunology, the only thing I could think of potentially sending there would be a DAT to detect for autoimmune hemolytic anemia. But I think, she's B12 deficient.
Yeah.
So I guess the question in my mind at this point, if I was taking care of this lady, is like, can I blame this all on metformin? Or should I be looking for something else? And you said her scan was normal and there's no other reason to suspect anything else at this point. So that's kind of where I'd be leaning.
You mentioned about pernicious anemia. Is there any workup you would do for that?
If you were worried, so I think the guidelines say if there's no other obvious cause of your B12 deficiency, then at that point in her age, you would worry a little bit about pernicious anemia. The only thing I really know is there's two blood tests you can send. There's the parietal cell antibody, which from my understanding is not, it's sensitive, but not specific at all. So if you just have run-of-the-mill gastritis, you just have inflammation in the stomach, those antibodies can be positive. So there's nothing there that tells you, this is pernicious anemia. You can send an intrinsic factor antibody, and that's actually not very sensitive, not as sensitive, but very specific. So if that test comes back positive, you've essentially clinched the diagnosis of pernicious anemia. I think the real clinical question is, well, when do you send that test? I think you could theoretically here with the metformin treat her and see how she does. And then if she's not getting better from a B12 repletion standpoint, you would know in pretty much 2 weeks, then maybe that would be your trigger to send specifically the intrinsic factor antibody.
Gotcha. Well, they were concerned a bit early, so they did send it off.
Okay.
They came back positive. Both of them came back positive. Antiparietal cell antibody was elevated at 48. The IF blocking antibody was also positive. They did send off some autoimmune workup for her liver disease, which came back negative.
Yeah, so I think you've confirmed that she's got pernicious anemia. She probably also has some contribution of the metformin as well, causing her B12 deficiency. So this lady needs aggressive repletion, probably IM, and then close follow-up. But, we could discharge her.
And that's exactly the thought. Pernicious anemia complicated with pancytopenia and intramedullary hemolysis. Thank you so much. So you did catch on pretty early, especially that extra bit about the intramedullary hemolysis. But then your comment about Dr. Run having a similar case made me think of, did we accidentally copy this case again? Anyways, so for his hospital, because this was a couple years back, his hospital course, was starting on daily B12 IM injections, then transitioned to weekly. When she started injections, all her symptoms started to improve. And so nausea, vomiting, has had better PO intake, was able to eat more. She followed up with Dr. Blinder in clinic, eventually transitioned to monthly B12 IM injections. And even with that, her last labs got a year ago, was the last follow-up she had. CBC normalized completely. You can see your hemoglobin is back to, very high, 15.3. Everything else is normal. Actually, now she doesn't even need to follow up with the hematology clinic at this point. She did see Dr. Crippen for regards to the cirrhosis. They think it's mastoid with regards to that. So I'll talk a little bit about B12. I'll try to be quick. I know we have 1 minute. And Dr. Patel kind of went through a lot of these things about B12 deficiency. Keep in mind that B12 and folate are needed for nucleic acid synthesis, so that cells that turn over, like hematopoietic cells, are primarily affected. It can occur from decreased intake or decreased absorption. We highlight a few things there: vegan or strict vegetarian diet. Think of your patients with bariatric surgery as well, or any malabsorption syndromes like patients with IBD. And then metformin are certain meds that can do it, like Dr. Patel mentioned. There are some classic signs. It's a lot of non-specific stuff. There is glossitis, kind of a hint that we talked about with the tongue changes. The neuropsychiatric changes are probably things you remember more from med school. There's affecting the dorsal columns. I think some people have some, maybe our applicants will probably remember this better, to be honest. But, the paresthesias, numbness, and gaze may affect the dorsal columns. It will show a macrocytic anemia plus or minus pancytopenia. And the pancytopenia really comes up because eventually it's just the red blood cells are affected, but then other cell lines can't make and catch up with the lack of B12 needed for nucleic acid synthesis. We also usually think of this as a smear that show hypersegmented neutrophils, which she did not have. I'm not too sure why that was not present in her. I wasn't able to figure that part out. The hemolysis is actually due to premature destruction, and that's within the bone marrow itself. Don't forget that B12 and folate is megaloblastic, which means that the RBC precursors are large, but macrocytic anemias include many other causes: alcohol, liver disease, hypothyroidism, meds, and blood dyscrasias. Measuring the folate B12 was the first step. And then, like Dr. Patel mentioned, if they're kind of borderline, you want to check an MMA. They also recommend homocysteine. There's kind of a way you can figure out which one is which based off of those levels there. A little bit about pernicious anemia specifically. It's a B12 deficiency due to autoantibodies that interfere with B12 absorption. I think that's a decent size to see. I was worried about that. But essentially, you need B12 to be bound to intrinsic factor to be absorbed properly. Intrinsic factor is made by parietal cells in the gut. And so if you have antibodies destroying parietal cells or antibodies against intrinsic factor, you can't absorb B12 enterally. So any treatment actually has to be done parenterally, in this case in the form of IM administration, and she did great with that. And I appreciate you all standing 1 minute past time. Again, let's give a round of applause for Dr. Patel for a great discussion. Thank you. I was totally read about that. Dr. Gary. Yeah.